about is the V-Fib algorithm. This is going to be the most common algorithm that we're going to talk about. So it's just going to happen. They're going to go into V-Fib. It's the just shortcut, the secret to ACLS. It's going to be V-Fib. All right. So I like to teach you a few mnemonics to get us through the initial assessment process. Okay. One of my mnemonics that I use is vomit. All right. When you talk about running a code, it makes you want to vomit.
Really?
Right. Everybody feel the same way?
Yeah.
All right. So V stands for vital signs. Right? Why is that important? Well, part of our VLS survey, we check for a pulse, right? All right, so we get a pulse. How about O2? That's also very important as well. Oxygen, right? M for monitor. Let's go ahead and get the patient connected to the monitor. I stands for IV or IO. And T stands for team. Let's get our team together. All right. So you can use this mnemonic several times. You can use it in your initial assessment phase. You can also use this mnemonic whenever you get say we get a rhythm back. We're in a PEA or a systole, or we're in we actually have ROSC or ROSC, the return of spontaneous circulation. So we can use this several different ways. And we'll talk about those ways here in just a second. So back to what I was talking about with V-Fib. All right, V-Fib, I like to teach brothers and sisters, okay? Brothers, that's our vasopressors, right? So that's our epinephrine or our vasopressin. So our sisters, that's our antiarrhythmic, right? So we're going to use amiodarone today. Amiodarone, we have two doses, 300 and 150, right? That's our two different doses. So with that said, we only have two sisters. One of them's name is 300, the second one's name is 150. Brothers, we have an unlimited supply of brothers, all right? So when we talk brothers and sisters, the rule is you cannot put a brother in the same room with another brother at the same time. Why is that? Well, they're going to fight, right? We got to put a brother and a sister, a brother and a sister. What happens if we put two sisters in the same room at the same time? They're going to fight. So with that said, we give epinephrine or a vasopressor every 3 to 5 minutes, as well as the amiodarone is also given every 3 to 5 minutes in between the first and the second dose. So patient goes into cardiac arrest. We'll just go ahead and change colors here. So deal with red, right? So patient goes into cardiac arrest. We draw the unhappy sign. We vomit, right? Vital signs: oxygen, monitor, IV, and team. So vital signs. Well, we probably don't have any vitals, right? O2. So the person who's doing that, that's bagging the patient with the bag mask, let's go ahead and get that connected to supplemental oxygen so that we were administering 100% FiO2. Monitor. Let's go ahead and get the pads connected to the monitor. Connected to the patient. So pads connected. IV or IO. At this point, we can establish an IV or we can get it intraosseous. With that said, we would use the drill gun, and we'll show you that here in just a little bit, or you can use the regular, I call it twist and stick. You twist it and you get it to go in, and hopefully it works. After that is the team. So we've got a great group today. I would say I want you on airway, I want you on meds, I want you on compressions, backup compressions, I want you to record, assign your team roles, okay? Get your team to work for you so that way you work more efficient, all right? All that said, we got the patient finally connected to the monitor. We analyze the rhythm. So I want you to say it with me. When I see V-Fib, I must D-Fib. Your turn.
When I see V-Fib, I must D-Fib.
All right, so we go ahead and we saw V-Fib there, a bunch of squiggly lines. There's no correlation. What do? D-Fib. All right, so we do 2 minutes of CPR. After 2 minutes of CPR is up, we analyze the rhythm. Well, I got a bunch of squiggly lines again. What do? I D-Fib. I see V-Fib right now. I've got a D-Fib. So I go ahead and shock this patient, right? So remember, note that we shock twice before we start our drug therapy. Just like anything else, we try the most non-invasive approach first. We tried to shock twice, didn't get a response, so now we start our drug therapy. We've got brothers and sisters. Which one do y'all think that we're going to give first? The brother? We're going to send the men in first. We're going to throw a brother in there. So we're going to go ahead and give our 1 milligram of epinephrine, IV push. We're going to circulate this epi in for 2 minutes. 2 minutes of CPR is up. We go ahead and analyze the rhythm. This is what I have. What do we do?
Shock 'em.
Shock. Now, the last drug I gave was a brother, which was epinephrine. What drug do you think I give now?
Sister.
Amiodarone, 300. All right, so we're going to circulate that in for 2 minutes. Let's go over here and scratch off. Our first sister's gone. All right, 2 minutes of CPR is up. We analyze the rhythm. Bunch of squiggly lines. Not good, right? What do we do? Shock. So last drug I gave was my amiodarone 300. What drug do you think we're giving now? We can, excellent choice. I'm glad you guys brought up the vasopressin. We can do vasopressin, or we can give epi. Okay? Vasopressin is a substitute of epinephrine. Okay? It's given in place of epinephrine and can only be given in place of the first or the second dose of epinephrine. All right? If we pass the second dose and we don't give the vasopressin, it can no longer be given. All right? So vasopressin, 40 units. Epinephrine, 1 milligram. Take your pick on what you want to give. Okay? We circulate that drug for 2 minutes. 2 minutes of CPR is up. We analyze the rhythm. Bunch of squiggly lines. What do? Shock. Shock the patient. So what drug can we give now? We're going to give our amiodarone. We've got to look at what we just gave. This drug right here. Is that a brother or a sister? It's a brother, so now we have to give a sister. All right? So we go ahead and give our amiodarone. This is going to be our 150. Another one bites the dust. We already lost our second sister, so we have no more sisters to give, right? We circulate this in for 2 minutes. 2 minutes of CPR is up. We analyze the rhythm. Still have V-Fib. What do? D-Fib. All right. What drug do you think we can give now? Epi. All right. We circulate the epi in for 2 minutes. After 2 minutes of CPR is up, we analyze the rhythm. We have V-Fib. What do? Shock them. So here's the thing. What drug do we give now?
Epi.
Well, what drug did we last give? We just gave epi.
And you can't give any more amiodarone?
Can't give amiodarone because we don't have any more. Vasopressin, we should have given vasopressin here or gave it here. So this is the hardest thing for us to do, is to not give any drug at this point. It seems like epinephrine is always our crutch. We want to pull epinephrine out of our back pocket and say, all right, it's time to give epi, it's time to give epi. But we don't always need to give epi that fast. Because how fast do we give epi? Every 3 to 5 minutes. So if you think the whole brothers and sisters thing, essentially what I'm getting you to do is get off the train of thought where you think, how long has it been since my last epi? Or what you're doing is you're focusing your thought pattern now on what was the last drug that I gave. So aids that you can do to help out with this. If I give drugs, you set them down. You know, you get the boxes of the medication after the med person delivers it, and you set the drug down, right? So 2 minutes of CPR is up, you know that, oh, last drug I gave was epi. So in the event right here, when I put this X, if we have to give something, let's give a flush, okay? So we'll set down just an empty syringe. Boom. We gave a flush. All right? So we gave a flush. We waited 2 minutes. 2 minutes of CPR is up. We analyze the rhythm. We've got V-Fib still. What do? D-Fib, right? All right. Now what drug can I give? Epi. So now we can give the epi. All right. So we're going to take this same code. I'm just going to erase this because I ran out of board. 2 minutes of CPR is up. We analyze the rhythm. I got V-Fib. What do I do?
Shock.
Shock. All right. We go ahead and shock the patient. What drug can I give? Remember that I just gave epi. Cannot give anything. Let's give a flush if we're going to give something. 2 minutes of CPR is up. We analyze the rhythm. We still have V-Fib. Oh, is this ever going to end? Shock, right? Now what can I give? Epi. We're going to do that same thing. 2 minutes of CPR. We analyze the rhythm. You guys getting the hint?
Yeah.
First thing we do is we shock. We don't give anything. Excuse me. 2 minutes of CPR will be up. And we'd analyze the rhythm. So 2 minutes of CPR. We analyze the rhythm and oh my goodness, the miracle came, right? We have organized complexes. What is the first thing we want to do? Check for a pulse. At this point, think again. We're going to vomit on this patient again, right? What is the first step in vomit? Vital signs. All right? Checking for a pulse. That's our first vital sign that we're going to obtain. So we check for a pulse. We say, all right, patient does not have a pulse. So if I have organized complexes on the monitor with no pulse, what does that tell me? My patient is in what? PEA, right? So we're going to write PEA, pulseless electrical activity. So our first drug of choice for PEA, it's basically brothers and sisters without the sisters. All right, all we have is just the brothers. So first drug of choice would be epi. So we go ahead and administer our 1 milligram of epi. Circulate that in for 2 minutes. 2 minutes of CPR is up. We analyze the rhythm. We still have organized complexes. What do we do? Check for a pulse. No pulse. What do we do? Continue CPR, right? Because remember, same rule applies. I cannot give anything here. If you give anything, make it a flush. 2 minutes of CPR is up. We analyze the rhythm. Still have organized complexes. What's the first step I do? Check for a pulse. Still no pulse. What do I do? Epi. You guys see where I'm going with this? We're getting you in the habit of not giving that epi back to back. That is the goal. We want to make sure that we're giving epi and we don't give anything. Epi, then we don't give anything. Because if you look at the time frame, we're right at about 4 minutes where we should be, somewhere in between there. What is the goal of epi? Every 3 to 5 minutes. 4 minutes falls perfect right in between there. All right? 2 minutes of CPR is up. We analyze the rhythm. Still have organized complexes. First step. Check for a pulse. No pulse. Continue CPR. Not giving any drug there. All right, 2 minutes of CPR is up. We check for a pulse. We got a pulse. Amazing. All right, so we got the pulse. That's just the start. So now we're going to enter our return of spontaneous circulation, right? Our ROSC. So essentially with this, what we're going to talk about is vomit again. All right, what do we want to know? Vital signs. Blood pressure is 70/30. Is the systolic blood pressure greater than 90?
No.
No. So you think 90 is a good cutoff, right? All right, so it's 70/30. What do we do to fix a low blood pressure? Let's give fluids. Typically, we give how much fluid? At least a liter, right? So 1 to 2 liters of fluid. And we're going to make that an isotonic crystalloid. Okay? So we fixed that. And the question that we want to ask when we're bolusing this fluid is this patient post-resuscitation V-Fib? Yes. They were in V-Fib, right? So can we make that chilled saline and possibly induce hypothermia? We would cool them down to how many degrees? 32 to 34 degrees. And that's Celsius, by the way. All right. So what are some of the contraindications of us chilling this patient down? How about if they're responding to verbal commands? Because they're going to say, it's getting a little cold in here. So, sir, can you squeeze my hand? If they can squeeze your hand, by all means, we're not going to chill them, right? All right, so We induced the hypothermia. We fixed the V so far. Now, let's talk about O. O is going to be our oxygen. You're probably saying, well, I already got this person connected to oxygen, right? So let's go ahead and consider intubating this guy. A healthcare provider is sitting there bagging away. So let's control that airway, all right? So let's call for some sort of endotracheal intubation. And now we have the time to do that. Because during the code, how many seconds can we stay off the chest? 10 seconds or less. So 10 is the cutoff. M for monitor. Well, what can we monitor? Well, we just intubated the patient. So how about end-tidal CO2? That would be good. What is our good range for end-tidal CO2?
35, 45?
35 to 40. So 35 to 40. Sometimes you would think 35 to 45 would be good, but we'll want to call it 35 to 40. So
And what is that, 35 to 40?
35 to 40, that's our end-tidal CO2. Okay?
And how do you tell that?
It's detected on, you can get that off of the endotracheal tube. There's a little device that attaches to the end of it, and that's how we actually get our waveform capnography. So you'll see that. They also have a side stream nasal cannula that you can use if the patient is alert. Obviously, we can use that. It used to be introduced in the OR. The OR would typically, you would see them put the side stream nasal cannula on, and you would see their baseline end-tidal CO2 and kind of get the good understanding of what your patient's respiratory status is. So we've covered the M. We just monitored end-tidal CO2. What about a 12 lead? We can monitor their 12 lead, right? This patient was just in cardiac arrest. We should probably monitor a 12 lead to see if there's any kind of ischemia going on, right? How about the I? Well, we already have an IV established. Why do you want another one? Well, what can we get out of an IV? Labs. And it's a whole lot easier to start an IV on someone who has a blood pressure versus someone who doesn't. So let's go ahead and get that IV, another IV initiated. And as we do that, let's get IV labs. And then the T. This stands for team, right? Team, get this guy out of here. So let's either take him to ICU or to the cath lab, wherever they need to go, right? Let's get him to some definitive care. Any questions about post-resuscitation care or V-Fib or PEA? Now, V-Fib is also the same as VTAC without a pulse. Is everybody okay on that? If they have VTAC and there's no pulse, then obviously we treat it the same way. Asystole is treated the same way as we treat PEA. We give epinephrine every 3 to 5 minutes. That's all we do for that. All right. Everybody good? Good job, guys. No questions? All right. So the next code that I'm going to go through